Welcome, everyone. My name is Maher Abu Faraj. I'm a pediatric emergency physician at Arkansas Children's Hospital. I am pleased to present the ultrasound of the pylorus as part of the SAM narrated lecture series. During this lecture, we will review the clinical presentation concerning for pyloric stenosis, the indications for ultrasound, anatomy of the organs involved, tips for maximizing your success, and positive findings in pyloric stenosis. Finally, we will discuss some of the literature related to point-of-care ultrasound in this application. Pyloric stenosis is also called hypertrophic obstructive pyloric stenosis, which is what the name implies. It's hypertrophy of the pyloric muscle that leads to obstruction of the pyloric canal that connects the distal part of the stomach into the duodenum. Thus, nothing of the gastric content can pass through the pylorus into the duodenum. It usually presents between 2 weeks to 2 months of age, with the peak at 4 weeks of age. Those patients usually present with projectile emesis, and if you worked in an emergency department, you'll realize that most parents with newborns will describe their babies vomiting as projectiles. So you'll have to elaborate more and differentiate between projectile emesis that shoots across the room versus emesis just goes down the patient's cheek. It is non-bilious emesis, and those babies throw up after every feed, so they're always hungry and increasingly fussy, and as the time passes, they become dehydrated and lethargic. In clinical presentation, their abdomen or clinical exam, their abdomen is soft. The olive sign has been described in textbook. However, it's increasingly difficult to appreciate this in clinical practice. You will be looking for signs of dehydration, including sunken fontanelle, sunken eyes, dry mucous membrane, delayed cap refill, and skin turgor. And the classic board review question is about the metabolic derangement related to pyloric stenosis, which is hypokalemic, hypochloremic metabolic alkalosis due to loss of gastric acid with the vomiting. Pyloric stenosis is more common in firstborn babies of Caucasian descent, in male patients, and preterm babies. History of macrolide exposure or being bottle fed and smoking exposure increases the risk of pyloric stenosis, and also positive family history for pyloric stenosis increases the risk for it. Switching gears to ultrasound, now the first question is which probe I would use to perform pyloric stenosis ultrasound. As with any other abdominal application in pediatrics, a linear probe can be sufficient. Those patients have a thinner abdominal wall muscle and thinner abdominal wall fat, so we don't require a lot of depth, and this gives us very sharp images. So you can start with the linear probe for pyloric stenosis. To review the anatomy, on the right side here, we can see the liver and the stomach, and the most important thing is identifying the interface between the liver and the stomach. And the stomach starts here and curves into the right side. We can see the body, then followed by the antrum, transitions into the pylorus, which then transitions into the duodenum. On the left side here, we see the corresponding anatomy. We see the liver and the stomach here, and this is the interface we'll be looking for. And as you're scanning, you want to track it down and transition into the pylorus. See that transition here. Another part that we would like to review is the normal gut anatomy or gut signature. The intestine is made of different layers that appear differently on ultrasound. From the outermost layer to the innermost layer, we have the hyperechoic white line that corresponds to the serosa, the hypoechoic dark line, which is the muscularis propriae, the hyperechoic white line that corresponds to the submucosa, and then number 4 is the hypoechoic muscularis mucosa, and finally number 5, the hyperechoic mucosa, and then it goes in the opposite direction. So this is the normal gut anatomy that you would like to review, and we want to focus on the number 2, which is the muscularis propriae muscle. Now, scanning technique. Pyloric ultrasound is a technical scan. It can be challenging for many reasons. But in order to increase your success, you want to scan the baby in the parent's arm to provide some comfort. If possible, to put the baby in the right lateral decubitus while the parents are holding them. You want to feed the baby sometimes, and that will help to displace any gastric air upwards, and the fluid will go downwards into the closer to the pylorus, so you'll be able to see. Using a pacifier will keep the baby quiet so they're not crying and drawing air into their stomach. Using warm gel is very helpful. We used to have gel warmer where I used to practice, but we don't have it right now. So sometimes I can I take some gel packets and put it in a cup of water and microwave it for 10-15 seconds and test it on my skin before applying it on the patient skin to make sure I don't burn them. Or you can just take small amount of gel and rub it on the patient abdomen, like giving them a gentle massage until they get used to that feeling before putting a lot of gel on them. And finally, the most important advice is to save as you scan, because this will help you a lot. As you're reviewing your images, you can see if you catch the pylorus at one point, and freeze in one of the clips and do your measurement. Now, scanning technique, you want to start with the indicator towards the right side and the transverse orientation at the epigastric, just below the xiphoid process. And you want to identify the liver-stomach interface, that area where we're seeing the transition between the two organs. And then you slide downwards, track the stomach, and see the transition from different parts of the stomach into the pylorus. Now, theoretically speaking, this sounds very easy. However, with a fussy patient who's running around or like crying and wiggling, it can be difficult. And those images are just for explanation. One thing I don't want you to do is to hold the probe this way. This is the wrong way of holding the probe. You want to hold the probe close to the end of it and anchor on the patient body, because you don't want to slide away from the area of interest. Now, this is an example of a normal pyloric ultrasound, and we will review the top here. We have the abdominal wall layers and transition into the liver here, and we see the liver-stomach interface closer to the right side of the screen here. And as we're tracking, this is the stomach, and we see at one point those are the layers of the pylorus here. So the serosa, muscularis propriae, submucosa, mucosa, muscularis mucosa and mucosa. And we see actually gastric content traveling through the pylorus here. So this is a normal pylorus. Another example of the normal pylorus, and we'll go over a couple of more examples. We see the liver-stomach interface, see stomach here, actually caught some peristalsis also, and this is the distal part of the stomach, and we see the pylorus now curved this way. And you can see the different layer. This is the outermost layer, the muscularis propriae, submucosa, and then the other layers. And finally, this example also of a normal pylorus. Again, I want to highlight the liver and stomach interface. As you're tracking it down, you see this very faint kind of tube that connects the stomach into the duodenum. This is the pylorus, and it's very small. Sometimes it can be difficult to see. And one of the things that I wanted to highlight in those three examples, that it can look completely different between one patient and another. In this clip here, we don't see like a discrete pylorus, but you can see fluid traveling through a canal and probably going through the pylorus into the duodenum. So that's by itself tells you that there is no pyloric stenosis and no obstruction. Now, what are the abnormal findings in pyloric stenosis? One thing I want you to remember is pi 3.14. We measure two things in pyloric stenosis. We measure the muscularis propriae muscle or muscle layer in transverse orientation. So you do it from the top to the bottom, and normally it is less than 3 millimeters. And also we measure the pyloric canal length. So we take it from the beginning of the pylorus towards the end, and this should be less than 14 millimeters. Other things that we look for in pyloric stenosis, if there is flow through the pylorus. If you see flow, then that's normal. Lack of flow through the pylorus is indicative of pyloric stenosis. If the hypertrophy is so severe, it can push on the mucosa itself, leading to mucosal prolapse through this, and that looks like a little nodule into the stomach, and it's called the antral nipple sign. And one of the signs that you look for, sometimes fluid can pass through part of the pylorus, and as the pyloric muscle spasms, it pushes back into the stomach, and you see reflux of gastric of fluid into the stomach, which can be also a sign of pyloric stenosis. Now, in the next few abnormal examples, on the right side, we will have this normal example as a reference, just to give you a sense of how the normal looks like while you're looking at an abnormal image. So here in this clip is an abnormal view, and we can see the liver on this side, and this is the stomach and some gastric content. And as with looking to the distal part of the stomach, we see a very thick canal there, and that looks like a hypertrophied pylorus. We don't have a measurement for this one, but the most important point that I wanted to show you when I play this clip here, you see, as they were scanning, the baby was wiggling, maybe screaming, is moving, and you're sliding here and there. So you don't really have a great view of the pylorus. You catch it as you're scanning, and then you go back and freeze that image and do your measurement. And that's the importance of saving clips as you're scanning. Now, this is another example here, and we have the liver interface and the pylorus here. We can see a thick muscle layer. At the distal part of the stomach, we see a glance of it here, and then a very thick muscle layer, hypoechoic muscle layer here. And the measurement for this patient at the widest area was 4 millimeters, and the canal itself is 14 millimeters. If you notice here, the canal is more curved and we're measuring from one side to the other. We're not going through the canal. So you can do it both ways. If you do it from here to here and it's at the upper normal or more than the normal limit, then you know that if you do two measurements from here to here, for example, and then measure from here to here and add it up, it will probably be more than 14 millimeters. So when you do that, this measurement, this type of measurement, and it's more than the normal limit, then doing it through the canal is also going to be abnormal. Here is another example, and again, we're looking for the liver stomach interface, which is here, and as we're trying to track the stomach down, this is the distal part and the pylorus here, and we can see a very thick muscle layer here. And also, if we pay close attention, we see some antral or a nipple sign at that area. And for this patient, when it was measured, it was close to 5 millimeters for muscle thickness. Another example here shows you a significant hypertrophy where the pylorus is measured around 7 millimeters. This clip, I wanted to show you the antral nipple sign. We see the stomach here, some gastric content. We see the pylorus. We see the muscle layer here, the thick muscle layer. Although we don't have measurement, we can see the mucosa being pushed and projecting back into the stomach, showing us the antral nipple sign. And finally, in this clip, we see pyloric reflux. We don't see the pylorus itself, but we see a big portion of the stomach. And at the distal part at the bottom of the screen, we see some fluid traveling back into the stomach. And this is due to spasm of the pyloric muscle pushing fluids back in the stomach and creating turbulence. So pyloric reflux can be a sign of pyloric stenosis. Switching gear to evidence, this study was performed here in the US and where one PIM attending who is ultrasound trained and 6 PIM fellows recruited patients with concern for pyloric stenosis. They had 67 patients, 10 of them were diagnosed with pyloric stenosis. They had 100% sensitivity and specificity, and more importantly, there were no difference in the measurement that they got compared to the radiology performed ultrasound. Another point that we take out of this study, that's the 6 PIM fellows who had only 45-minute didactics to learn about pyloric ultrasound. They were able to recruit some of the patients, and 7 of the 10 patients that were diagnosed with pyloric stenosis were diagnosed by PIM fellows. The big point that we learned from this is that although pyloric ultrasound can be technical and challenging, it is an easy study to teach and learn and perform. Another study was performed in South Korea where a community hospital performed ultrasound, point of care ultrasound on patients, and they compared point of care ultrasound only versus point of care ultrasound followed by radiology performed ultrasound and radiology ultrasound only. And for point of care ultrasound, they had a very high sensitivity, close to 97%, and a specificity of 94%. Another thing that we take from that article is that there was a significant decrease in the length of stay in the group that had point of care ultrasound, which is a very important aspect in emergency medicine. So take home points from our talk. One, the abnormal findings. Pi, remember 3.143 is for muscle thickness and 14 is for the canal length. Looking for antral nipple sign, looking for lack of flow through the pylorus and reflex sign. More importantly, this is a very challenging study with frustrated parents, very hungry and fussy baby. Try to optimize your setting, scan on the patient in the parent's arm, try to put them in the right lateral decubitus, feed the baby warm gel, and save your clips as you're scanning because you may be able to catch a pylorus for 1 second and then go back and freeze that image and do your measurement. And finally, I will be happy to answer any questions. Please feel free to reach out to me at my email. And thank you very much for tuning in.